Hello, my name is Kate Chesterman. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify and Apple and Google podcasts. Please follow us to receive notifications about new episodes. And if you like what you hear, please consider leaving a review to help other listeners find us. You can also visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Today I'm going to be discussing Olecranon bursitis. The Olecranon bursa is a sac overlying the Olecranon process, the posterior tip of the elbow, and this sac contains a small amount of fluid. Its purpose is to provide smooth movement between the skin, subcutaneous tissues and the olecranon. Olecranon bursitis develops when this bursa becomes enlarged, and because of its superficial position, this usually occurs because of pressure, friction or trauma. Men appear to be affected more commonly than women, and there is an increased incidence in those between 30 and 60 years old. Olecranon bursitis is also more common if there is constant or repetitive pressure or repetitive elbow movement. This means that some occupations and activities are risk factors for Olecranon bursitis, such as gardeners, mechanics, plumbers and students, as well as those who enjoy, for example, javelin, weightlifting, cricket or gymnastics. Other risk factors include a history of autoimmune conditions such as rheumatoid arthritis, other inflammatory arthropathies such as gout or pseudo-gout, as well as immunodeficient states, for example diabetes, HIV, CKD, alcohol abuse, or those taking medications that result in immunocompromise. Finally, Olecranon bursitis can occur because of an isolated traumatic or penetrating injury. Olecranon bursitis can be classified into either septic or non-septic cases. Septic conditions are less common and are responsible for around a third of all cases of Olecranon bursitis. Staph aureus accounts for 80 to 90% of septic cases, and most of the rest occur secondary to beta hemolytic streptococci. Fungal infections and other bacterial infections are much less common, but may need to be considered if patients are not improving and in immunocompromised states. Infections are thought to penetrate the bursa either through breaks in the skin, which can be minute, or due to migration from another focus of infection across the soft tissues and into the bursa. Non-septic cases usually occur secondary to acute or repetitive trauma, overuse, or crystal deposition. The inflammation can occur either due to bleeding into the bursa or through the release of inflammatory mediators. Inflammation can lead to permanent damage to the epithelial lining of the bursa and can predispose to recurrent attacks. Olecranon bursitis will usually present with a discrete swelling that is palpable over the olecranon process. There is often a degree of erythema and warmth, and a contusion or abrasion may be visible if there has been recent trauma. The swelling commonly develops over hours to days, is usually mobile, and can be tender. In non-septic cases, the lump tends to be inconvenient rather than painful, although pressure can exacerbate any discomfort. A more generalised swelling of the joint should prompt a consideration of a different diagnosis, such as an inflammatory arthropathy. Movement of the elbow doesn't often cause pain, except at extreme flexion when compression of the bursa may be uncomfortable. If there is an unusual restriction of elbow movement, then alternative diagnoses such as a fracture of the olecranon process, if there has been a history of trauma, or a septic arthritis might need to be considered. The most significant diagnostic decision is whether a septic case is present, and it can be difficult to distinguish septic from non-septic cases. A septic case of Olecranon bursitis should be considered if the swelling is hot, red and tender, if there is an acute onset of symptoms with no trauma, if there is a laceration over the bursa, if the patient has fever or rigors, or if they are seeking medical help early in the condition. Septic cases should also be considered in the immunocompromised. Erythema, pain and fever are more common with septic Olecranon bursitis, but can be seen in non-septic cases as well, especially if secondary to gout or rheumatoid arthritis. So it's worth examining other joints for gouty tophi or rheumatoid nodules, which may give clues to the underlying etiology. The diagnosis of Olecranon bursitis is usually clinical. Investigations are not routinely required, but a blood test to check the white cell count and inflammatory markers can help if there is doubt about whether infection is present, although this shouldn't delay treatment if there are concerns about a septic cause. And checking urate levels and an inflammatory arthritis screen can be helpful if an underlying diagnosis is being considered. Imaging is also not done routinely, but an X-ray could be considered if there has been significant trauma and concerns about a fracture. And ultrasound or MRI can be helpful if there is diagnostic doubt. Aspiration of the bursa under aseptic conditions can be undertaken by those with expertise and equipment, and the fluid can be sent for microscopy and culture as well as crystal analysis. Aspiration can be helpful for both diagnostic guidance and to relieve symptoms, and I'll discuss the indications for this more fully as we move on to the management of this condition. So, how should we manage Olecranon bursitis in primary care? Well, if you are confident that the case is non-septic, then a conservative approach is encouraged. Patients should be advised to modify their activities and lifestyle to minimise mechanical stress and pressure on the inflamed bursa. They should avoid activities and positions that worsen their symptoms. Ice wrapped in a towel can be applied for 10 minutes every few hours for the first 24 hours, and simple analgesia such as paracetamol or oral or topical non-steroidal anti-inflammatory drugs can be recommended to manage discomfort if there are no contraindications. Compression bandages can also help to relieve pain, and elbow pads can help to reduce further trauma. The majority of cases will respond well to this advice and have a good prognosis. If the condition is refractory, then an aspiration of the bursa to relieve discomfort, and even a corticosteroid injection into the bursa can be considered, as this may improve recovery time and reduce the risk of recurrence. If the appropriate expertise is not available locally, then this will require a referral to secondary care. And corticosteroid injections should not be administered if there are any concerns about possible septic Olecranon bursitis. For septic Olecranon bursitis, it's recommended that the bursa is aspirated to dryness and the fluid sent for microscopy and culture, as well as crystal analysis. Again, this may require the involvement of secondary care if the appropriate expertise is not locally available. Patients with septic Olecranon bursitis should be given antibiotics, and these can be started empirically while awaiting culture and sensitivity results. As most septic cases are caused by Staph aureus, flucloxacillin is usually recommended as the first-line choice, or clarithromycin for the penicillin allergic. Antibiotic choices can be altered if required once culture results have been received. Recurrent aspiration may be required if the fluid reaccumulates, and a referral for surgical drainage may be needed for a pointing abscess, or if aspiration and antibiotics are not controlling the infection. Rarely, a bursectomy is considered for refractory or recurrent cases. If the patient is unwell, has a severe infection or extensive cellulitis, then they may require an admission for parenteral antibiotics. Concerns about a possible septic arthritis should also be referred for an urgent same-day assessment. Complications from Olecranon bursitis are thankfully rare. Secondary infections can occur after aspiration or corticosteroid injections, and fistulae can form following a spontaneous rupture of the bursa or surgical drainage. Septic arthritis, sepsis, or osteomyelitis occur rarely secondary to severe septic Olecranon bursitis, but by far the most common complication following Olecranon bursitis is recurrence. Patients can be advised on simple measures to try to prevent recurrence, such as avoiding excessive pressure on the elbow or recurrent trauma. Elbow pads may help to reduce the risks of recurrence, but this hasn't been proved in clinical trials. Management of any underlying inflammatory arthritis, such as gout or rheumatoid arthritis, may also reduce the risks of the bursitis returning. So, thank you all for listening. I hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com. Feel free to email support@GPnotebook.com if you have any questions, comments, or ideas for future podcast episodes. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts, which are designed to help make your lives a little easier and ultimately help improve the lives of our patients in primary care.